just leave the screen, leave yourself some room so you can actually see the screen. And then, let me see here. So what I thought we would do is we're going to go over a couple of cases, and we'll hopefully get the tumor board has not seen these cases. And we'll test them to see if they're right, if they come up with the right answer or not. But I think it'll give an idea of what we go through, what our discussions are like, what our decision making is like. So the first patient is a 58-year-old male who has been smoking for 20 years and has a 30-pack year smoking history during that time, had a cough and underwent a chest x-ray that showed an abnormality, and then had this CT scan. So Dr. Amy Rabinowitz, who is truly a remarkable radiologist, she is an amazing asset that we have at this hospital. Amy, what do you think about this? Yeah. Yeah. Here, let's see. Pass them around.
Okay. And before I start, Dr. Tunui's last slide lists some of the chest radiologists, but that's an old slide. We now have 8 dedicated thoracic chest radiologists here in our section. Some of the ones that were on there, one's retired and one's no longer here, but we have 8 fantastic people in our section who are specifically trained in, all we do is look at the lungs, look at the chest every day, 24 hours a day, 7 days a week, basically. So, so looking at it a lot, you get pretty good at it. But anyway, so here in the, can I have a pointer to show them? No?
Yeah.
Have a pointer? I could probably point. Will that work? Sorry. Or Dan, if you could point. No, I'm just kidding. So right here, so this is the lower part of, oops, sorry. There we go. This is the lower part of the chest. So this white thing that we're seeing here and this white thing here, these are the diaphragms, okay? So these gray things here with white dots in them, these are the most inferior part of your lungs, your lung bases. And here, this big white dot here, this doesn't belong here. This is not a blood vessel. So this looks like, I don't have a measuring tool here, but maybe a 2 centimeter, what we would call it a well-circumscribed lung nodule. And a nodule this size in someone who smokes, based on chest CT, you know, we would call this an indeterminate lung nodule. Sometimes people have lung nodules that are this size that end up being benign lesions or nodules from infection. But in somebody who's a smoker, who's not sick in the hospital, and this is incidentally picked up, a good percentage of these will end up being a neoplastic nodule, you know, potentially a lung cancer.
Excellent. So this patient had a PET scan, and the PET scan, which is a radioactive sugar, did have some activity in that nodule.
A little bit.
Little bit. And this is the scanogram. It's a little bit different way of looking at it, and there was no other uptake anywhere else. So Kevin, the patient wanted to know, should we biopsy this? Is this a biopsyable thing, and is that a good idea?
Yeah. So we do image-guided targeted biopsies. So the imaging guidance technology has gotten advanced so much in the last many years now. So a lot of these the masses that are deep inside under either CT, ultrasound, or the even PET-CT guided, we can actually take a tissue sample out of this pretty accessibly and pretty safely. But also, the technology has been advanced enough such that now the tissue, not only quality but also quantities, have gotten much improved over the years. So those allow not only the adequate diagnosis, but also a lot of different markers that are necessary for a lot of treatments options that we have.
And so sorry, Kevin Kim is our director of interventional pulmonology, interventional radiology, and biopsies things using a needle through the skin.
Yes.
So Dr. Homer is our pathologist. Rob, what do you think about your potential to diagnose something like this based on a needle biopsy? Do you think that would be helpful in this setting or not?
So first of all, I want to say that the biopsies that are obtained at Yale are amazing, actually. So one of the things we see here is we see patients referred who've been biopsied elsewhere. So we see biopsies from really every hospital in the state, and we see biopsies that have been obtained at Yale. And it's when you see a biopsy, you have a piece of tissue, and you can imagine if you saw a photograph of a relative of yours, and you saw their whole face, you'd recognize them pretty well. If you just see their ear, it might be a little harder to recognize exactly what you see. And so when you see a small piece of tissue as opposed to an adequate piece of tissue, it's trying to understand who exactly it is, but you only have part of the ear or maybe a little bit of the nose to go by. You have to use a lot of imagination. Whereas at Yale, we are much more likely to see the entire face. I would say that for a lesion like this lesion, my guess is that this lesion will be probably accurately diagnosed the vast majority of time. There certainly are times when we have a discussion about do they actually have the appropriate material, but I would think a lesion like this, which is a very round, very regular lesion, everything's pretty clean, would be likely to be diagnosable on a biopsy.
So this may be surprising, but we would almost never biopsy this. And the reason is if we biopsy it and it's cancer, well, we're going to take it out. If we biopsy and it's not cancer, because of what Rob was saying, there's a chance that we hit the part of it that didn't have the cancer in it, because cancers can be a mixture of scar tissue, inflammation, even sometimes infection. And so the way I describe it is taking a biopsy is like taking part of a book. A needle takes words, surgery takes out the whole book. And sometimes a few words tells you what you need to know, but sometimes it doesn't tell you the whole story. So if we stick a needle in this and it says no cancer, there's a 20% chance that there's still cancer in that. And what I tell patients is if somebody told you that there's a snake in your shoes and there's a 20% chance it's poisonous, you're getting rid of the shoes. So at least in Ohio, you would be getting rid of the shoes. I don't know what you people do here in Connecticut, but so as a part of management, this would be somebody where we would take them to the operating room and we would take this out, and based on frozen section, we would send it to Rob, and Rob would tell us, is this cancer or no cancer? And so Rob, your team said this was a neuroendocrine tumor.
So that would be right. So the issue there would be, so we're getting into we're getting a little deep in the weeds here, but the point is that even though we talk about tumors of the lung, the key concept is that there are different types of tumors, right? There's some things that are formed lesions like that, as Dan says, completely benign. You take it out, nothing's going to happen, you're done. There are some tumors where you take it out and we're worried about you. We think you need follow-up. This is really, something bad could happen. Maybe not today, but at some point it could. And then there's other tumors where it's like, maybe it will, maybe it won't, but the chances are relatively low. And so my job is basically to tell them where on that spectrum it is. If this looks really bad, this looks like so-so, this isn't so bad, or don't worry about it, this is all good. So if I saw something like that, which was nice, round and regular, and you said neuroendocrine, and given the fact that the PET scan was pretty weak, that was not exactly a blindingly thing, it's probably going to be one of the lower grade tumors, which should be out. But if it's out, you're probably going to be okay.
So interestingly enough,
right.
We took it out and there was a lymph node that was positive, and this is actually small cell.
Interesting. That's unexpected.
So Amy, why would that surprise you based on the imaging? Is that a normal, so the cancer of the lung, there's small cell and non-small cell, and they behave very differently. They look differently under the microscope and they behave very differently. Is that a common picture for small cell?
No, it's not. And sometimes we do see things at imaging that don't really correspond with what the pathologist is seeing, or maybe what's going on clinically, and that's why our multidisciplinary tumor boards are invaluable, because we all discuss and say, well, you know, could it be this, and kind of come, for the most part, or most times, come to a consensus. But not everyone, not every patient reads the book and is, you know, follows the typical classic, when you get to the chapter on lung cancer, what it should look like. So usually when we see lung cancer, there are different types of lung cancers, there are different cell types. We can guess, you know, based on imaging what cell type it might be, but Dr. Homer here, the pathologist, is the one that's really seeing the cells. We don't quite yet, maybe in the future, our CAT scanners don't have microscopes, so we can't see the actual cells. We're just trained to find the disease, describe the disease, and, and did you change that?
Yeah.
Oh, to figure out most likely what the disease is going to be. But small cell lung cancer in general presents with very large lymph nodes in the mediastinum. A lot of times we don't even see the primary tumor in the lung, but they're usually central meaning located in the center of the chest, kind of in near where the heart is, near where the pulmonary arteries are. When we see lung nodules that are peripherally located, the majority of those are going to be non-small cell lung cancers, or what we would say adenocarcinomas.
It does point out the fact that even though the clinical features, the radiology are very helpful, in most of the time, at the end of the day, you know, the pathologist is the one who gets to decide what the final diagnosis is. So even though, to me, and I think to most of us, would not have guessed that that would have been a small cell, the final microscopic diagnosis is in fact the final diagnosis. And that's really the way things actually wind up.
That's a great point. So we usually treat things as if they're very dangerous cancers, and hopefully are pleasantly surprised that they're not, just so that we don't underreact or to disrupt things. Or so a common question is, there was a lymph node metastasis and we didn't see it on this PET scan. How could that be? The PET scan was only done a week before. And the PET scan, it's a radioactive sugar. And so things that use sugar give off a signal, but it only is as bright as the number of cells that are giving off the signal. So the way I describe it is, it's kind of like looking for people wearing pink shirts in a football stadium. They can be there, but if there's not a lot of them sitting together, they don't stand out. So a PET scan, even though you have a PET scan, it's our best way to look for cancer that's spread, but it misses things that's smaller than, say, the size of a small grape. So I think that's important. So Rick Wilson is one of our superstar medical oncologists. He's a surgeon, he's a scientist and a medical oncologist, and he knows a lot about small cell. He knows more about small cell than anybody up here. So he's the only medical oncologist up here. Rick, what do you think about this? Is this somebody you'd give chemotherapy to? Are there any trials or anything? What are your thoughts?
So I think, as we've heard already, you know, this is sort of an unusual presentation for a small cell lung cancer. You know, a small cell lung cancer is a type of lung cancer that actually tends to spread fairly early in presentation, meaning that most of the time when we meet someone who has a diagnosis of a small cell lung cancer, we usually can already see evidence of it in other places as well, just because it tends to spread fairly early in the course of its development. This is an unusual situation where, from the imaging studies, we didn't see any evidence of this being in another location, but as we heard, in a nearby lymph node, there was some evidence of involvement of the small cell cancer in that node as well, even though you couldn't see that on the scan. So, you know, in a situation like this, you know, that tumor has now been removed by surgery. But because we know that a small cell lung cancer is one that tends to spread early, we would be concerned that there could be additional cancer cells, perhaps too small to see on scans, but could be in another location. And so this is a situation where I think we would be considering, you know, additional therapy. Small cell lung cancers tend to be very sensitive to chemotherapies and to radiation. And so, you know, this is a situation where, even though really the only thing that had been seen on the scans has now been removed, I think we'd be concerned that there are additional cancer cells there. and that additional therapy might be indicated.
Great. Yeah.
On something like that with the PET scan, would that, in that case, small cell, is there a PET scan for the specific mutations that only shows, so it would show that cancer or that mutation anywhere in the body? You can pick it up with the scan.
So there, when you're talking about a test, there's sensitivity and specificity. So sensitivity is it finding everything that there is to find? Specificity, is it correctly saying what it is? So if you have a really sensitive test, you never miss anything, but you pick up a lot of things that actually aren't anything. If you have a really specific test, then you only find the cancers, the lung cancers, but you miss a lot of them. So that's a great question. There are these metabolic tests. So this is a radioactive sugar. There are more and more tests that are based on specific things that cells are using. And so there's a dotatate scan that is very specific for a specific type of cancer. So the field is moving in that general direction, but I think that it's still at a point where you're sacrificing, it's very specific, but not as sensitive, if that makes sense. We do a lot of work here on blood tests, and one of the radiation oncologists, part of the research we do with him, his name's Abhi Patel, looks at actually little fragments of DNA that are floating around in the bloodstream of cancer patients. So if you imagine how sensitive that is, you literally have, I'm going to say, a gazillion cells that are breaking and dying and shedding DNA, and one cancer cell's DNA can be teased out of that haystack of other fragments using these advanced technologies that Dr. Patel is innovated. All right. So the next case, this is a 78-year-old female significant smoker who had a cough and got a chest x-ray and was found to have this lesion, which is lighting up on the PET scan, which is that bright area there. There's no evidence of lymph nodes, but we need diagnosis of this because we got a brain scan, and unfortunately there were 2 areas in the brain that were showing abnormalities. Aaron, Aaron's one of our interventional pulmonologists who does a lot of our staging for us. And what do you think about this? How would you prioritize? What would you go after, and how would you get a diagnosis?
Certainly. So, so as Dr. Boffa said, I'm one of the interventional pulmonary doctors, which means I'm a pulmonologist by training, but I specialize in doing pulmonary procedures. So one of the things that I do are procedures called bronchoscopies, or EBUS. And so when we think about diagnosing and then subsequently managing patients with potentially lung cancer, we think about to obtain a tissue sample. We think about doing a biopsy that is at first the least invasive thing to do, that will provide us the most information about staging. So Dr. Tanui talked to us a bit about staging in terms of lung cancer, and many of you are also probably familiar with it. So in this case, the patient has lesions in the brain that look consistent with potentially metastatic disease. And so we would classify this person, if we assume that these are positive, as a stage 4 disease. Obviously, there are challenges to biopsying a brain, right? So we then assume that this potentially is a foci of metastatic disease and turn to the lung to try to biopsy the lung in a non-invasive way. So this lesion would be very amenable to doing a biopsy via bronchoscopy, which is a procedure that's an outpatient procedure. Patients are put under anesthesia, and we use a long, skinny camera that goes into the mouth and down into the airway to find this lesion. The advantage of doing it this way, as opposed to a technique that Dr. Kim described before, going through the skin, is even though the PET scan here potentially didn't show any lymph nodes lighting up, As Dr. Boffa talked about, the PET scan's not 100% accurate. And so there's the potential that this malignancy that we know is potentially spread to the brain may be present in some of the lymph nodes of the chest. And in order to think about the most comprehensive way to treat this cancer, we would sample both this lesion and all of the lymph nodes in the chest at the same time to determine if any of the lymph nodes were involved.
Great. So this is stage 4 cancer. That is a cancer that all through medical school a long time ago for me, that was not a curable cancer. And I would say that we have made great progress at the beginning identifying cancer and great progress in stage 4. And I think Scott Gettinger is going to talk about chemotherapy innovations for stage 4. But Roy Decker is one of our radiation oncologists. He's not only an active clinician, he leads some clinical trials in this subset. Roy, can you tell us what is new and exciting in this entity of limited spread cancer?
So you know, along with Dan, you know, in my training, we were taught that when cancer had spread beyond the initial site, it was really no longer appropriate to think about, you know, aggressive and potentially curative therapy. What we've learned is that there are some patients who have really very limited sites of disease. So this patient's a good example. Their primary tumors in the lung, they have 2 small spots in the brain, and, you know, according to Dan, that's all they have. So what we've learned over the last several years is that treating these patients aggressively with surgery or radiation or ablation interventionally can improve their survival compared to just doing chemotherapy. Now, we do think that chemotherapy or immune therapy is still critically important in their care. So we're just adding on local therapy to be aggressive. For those of you who are not familiar with radiation, you know, so we deliver X-rays that are not fundamentally different than the X-rays you get during a CT scan. They're just higher energy. They're very carefully focused and aimed very precisely at the tumors we want to treat. And you know, in this patient with these small brain tumors, one of the things that we would consider is using radiosurgery. It's a single-day treatment where we can treat these small tumors with really sub-millimeter accuracy, sparing the brain around them. And honestly, we have an outstanding chance of controlling them. So, you know, our new paradigm in our group is to talk about these cases and think about how we can, you know, how we can add local therapies such as surgery, radiation, and ablation into their care.
Great. So the last case I wanted to talk about is a 50-year-old gentleman, a heavy smoker, who developed a cough. You're seeing a pattern here, got a chest x-ray, and was found to have this nodule. There are some irregular borders. It looks not dissimilar to a, Amy, I don't know if you want to highlight the nodule and comment on its friendliness or lack thereof.
So when we see nodules or spots in the lung, when we describe them, one of the things we want to look at carefully and describe also are its margins. And unlike the first case that we saw that was a nice, sharply, the one that had the nodule in the left lower lobe, it was nice and perfectly round, and you could take a pencil and trace its margins. This one isn't perfectly round. This has little tentacles or little spicules coming off of it. And while, again, just like the first case, that ended up being a lung cancer, when we have nodules that are more irregularly shaped, that's going to raise our suspicion, or based on imaging, that's going to have a much higher likelihood of being a lung cancer rather than the smoothly marginated nodules. But again, just like the first case, the nice sharply marginated ones can be cancer too. But this is a more worrisome appearance when the margins are irregular or spiculated.
So we got a PET scan and there's some uptake in it. I didn't show you all of the images, but one of the curious things is when we got the PET scan, you also get a CT scan, and it had changed a little bit, and it had gotten just a little bit smaller. It was a very subtle thing. There was about a month in between. Normally, a garden variety cancer should increase by 25% in its diameter in about 3 months. So if it's an inch, it'll go to an inch and a quarter. That's just kind of a ballpark of how things grow. So if something is discovered in you, if you march it back, if it's big enough to be seen on a CT scan, it's probably been in you for a couple of years on average. But Polly, this is something that got a little bit smaller. What are some other things this could be?
So the differential for lung nodules, and we look at these all the time, there's 3 big categories. One is infectious, and that could be a current active infection, or it could be an infection that you had when you were younger and didn't even realize. Some people are exposed to tuberculosis and don't realize, but even a pneumonia or something that you had along the way could leave scars. The other big category that we look at for pulmonary nodules are the inflammatory diseases. So if you have any of the kind of arthritis type things or vasculitis, just like they leave nodes, kind of most people see them on their extremities, but you can also get them in your lung. And then the third big category that we've been talking about are malignancies. And these could be primary lung cancer, or they could be a cancer from somewhere else that went to your lung. So this is a patient where we would have them come in and do a really thorough history about any, infectious history that they had. Did they grow up in a place where there was a lot of tuberculosis or a lot of fungal infections? We would just do a really thorough history about their other comorbidities, and then perhaps they have another malignancy or something else that's concerning.
So we took this patient to the operating room, and which is our normal, we don't go right to the lung cancer operation. So the lung cancer operation, normally the lung is separated into lobes. There's 3 on the right, 2 on the left. I call them slices of an orange. They're individually wrapped but stuck together. We don't do the lung cancer operation for most patients is to remove the lobe. We start with taking just a piece of the lobe, letting Dr. Homer and his team look at it. And sure enough, this was not a cancer. It was inflammation. And so that it was a very small, minimally invasive surgery. And we did not move forward to the lobe. Just one last thought. Polly, you did mention that that knowing a patient's prior cancer history, because cancer in the lung can either start in the lung or come to the lung from somewhere else. Frank Detterbeck is in the audience. If you don't know Frank, he is a literal giant. He's not a tall man, but he's figuratively a giant in the field of lung cancer. He's been quoted in every major newspaper. He's published in every major journal. He's truly a rock star in lung cancer. Frank, how do you put together somebody has a history of another cancer and then pops up in your clinic with a new lung nodule? How do you figure that out? And what are sort of some baseline risks that, is it a new lung cancer or is it their old cancer that's showing up in the lungs?
Well, I think you have to consider a lot of different things.
You said the mics.
I think it's always a judgment call where you factor in a lot of different aspects. So one aspect is what type of cancer did they have before? There are skin cancers that are really not, aggressive and not likely to ever show up anywhere else and pretty low grade. And, if that's what you're dealing with, that's very different than if you're dealing with a more aggressive cancer. I think another thing is, when they had their previous cancer, was that a very early stage cancer that has a very low risk of ever showing up again? Or was that, a higher stage colon cancer or whatever, where you say, risks are going to be fairly high, something's going to show up again. I think another thing is the time period. If it's been a long time since their previous cancer, it's getting to be pretty unlikely this is related. And then there are imaging characteristics. So if it's something that's come from somewhere else and gone to the lung, it tends to look fairly round most of the time, but tends to be in the lower lobes and not the upper lobes. There are a number of things based on their history, the type of cancer they had, and a number of things based on the imaging that, really dramatically, I think, influences your
estimation of the probability that this is a new primary lung cancer versus something related to a previous cancer that they might have had. And so usually you can put it together in a way where you can make a pretty good judgment call, pretty accurate judgment call on what it is.
Well, before I dismiss this panel, does anybody have any questions for them? Yeah.
And you haven't talked about AI at all in all these disciplines. Is artificial intelligence creeping into this arena in any?
Absolutely. So artificial intelligence, so using computer algorithms to go through series of images to try to identify, so where AI is really showing promise is if you screen somebody for lung cancer, 25% of the nodules that are identified are not cancer. Sorry, 25% of people will have a nodule, 99% of them are not cancer. So how do you determine is a given nodule cancer or not? So AI is really gaining momentum in that space. That's something that we're working on here, but is being worked on in several institutions. There are nuances that AI has an advantage to. They can look at things. There's things that AI can consider that we don't consider. You know, the size of the spike in relation to the size of a rib or something that you just wouldn't think to make that comparison. But there are nuances to the history, to the progression over time that only a radiologist is going to be able to tease together. So I think it's got tremendous promise as a complement to radiology, not as a replacement.
Well, one thing with AI, we're using it here. We kind of rolled it out more experimentally, but when we're looking at studies in different parts of the body, so I know in the emergency room, when people come in looking for brain bleeds, blood in the head, so we have a system that looks for that and will alert the radiologist. You know, if we have a long list of cases to read, a study will pop up with like a red flag, and they'll go and look at that and see, you know, is the computer right? Is there something super urgent on this study that I need to, you know, let the clinician know about right away? So I don't know how I think it's been performing very well with the brain bleeds in the lungs or in the chest arena. We have this set up to look for blood clots in the lungs, so pulmonary emboli. And just, you know, over the past maybe 4 to 6 months, we have it kind of installed on our computer systems where we read the studies, and a lot of times it's correct. A lot of times it picks up things that aren't, it has a lot of false positives. So it's not perfect, but we always look at, you know, what it's flagging, and sometimes we completely agree. Other times we're like, no, that's, you know, it's pointing to a vein. It's not a blood clot in an artery, or it's pointing to an airway that's filled with a little mucus or secretions. So it's not perfect, but it's definitely, you know, nice to have like the extra set of eyes and to flag cases for us to look at them more quickly if there actually is an urgent finding.
So I would just add a comment to that. I think sometimes AI is oversimplified and oversold. So certainly we can use computer technology in a lot of ways, and we are working, you know, there's all kinds of things going on to, you know, develop that and to use that, and I fully support that. On the other hand, you got to remember what AI is doing is it's saying, okay, I'm looking at, you know, 10,000 patients and looking at their scans, and I'm coming up with a prediction based on an average of 10,000. Okay, that's fine. Now, if you want to be treated as an average of 10,000, then all you need is AI. But I think for most people, I don't want to be an average 10,000. I want you to take whatever you can learn from 10,000, but then I want you to apply it to me as an individual. I want you to take into account sort of other factors and see how well does that actually apply to me. And I think that individualized judgment still ends up being a physician judgment. Now, we need to build the AI tools so they can enhance that ability to individualize that to people. But we have to keep in mind that we have to keep that. And sometimes I get the feeling that this field of AI is sort of moving the, I don't know, the industry and the tech people and so forth are sort of moving it into a sphere where it doesn't necessarily help enhance our clinical judgment. It's sort of thought more of to replace it. And I don't really see that as being really where we want to end up. So I think that it's exciting. There's a lot going on. I think we still have a lot to learn about how to make that really be most useful in the individualized patient care, which is really the fundamental aspect of medicine. You know, that's really what happens.
I just wanted to make one other comment about metastatic disease, which is that pathology is also not always, but frequently useful in terms of helping decide. So while getting a biopsy might be, you might get a negative result that is not very helpful, might not show the tumor, but a significant percentage of the time, pathology is actually also very helpful in deciding whether something is primary in the lung or.
That's a critical point. So there are definitely times when we biopsy. We use biopsies to rule in or prove that something is something. We don't use biopsies to prove that something isn't something. It's a subtle semantics, but did you have a question?
I just want to know if you're seeing more lung cancers in non-smokers and not environmental smoking.
So 1 in 7 lung cancers happens in somebody who's never been a smoker. Frank, I don't. Is there? Do you know? Have a sense of what the trajectory is? Or is the prevalence of non-smoking cancer on the rise? I don't know that I've heard that, but Frank would know.
Well, I think it's, I think it's on the rise. But the other thing is that I think we need to take a, I don't know, more sophisticated approach. So there was actually just a study that was published from Korea where they did a pretty fancy kind of genetic analysis, and they had a lot of epidemiologic data about exposure to smoking and so forth. And there are certain genetic patterns of mutations and things that are just very characteristic of people that smoked. And then there are others that are not. And they actually found that there was I don't remember the exact percentage now, but there's a pretty sizable chunk of the people who do have a history of smoking, but their cancers don't seem to fit that pattern. Their cancers seem to fit the pattern of people that are non-smokers. They don't seem to have that characteristic mutational, lots of different mutations and mutational signature of smokers. So I actually think that we've had a crude view of just saying, well, did you ever smoke in your life? And okay, you quit 30 years ago. Well, we're still going to count that as smoking. But I think we've counted a lot of cancers as being tobacco related. Maybe not a lot, but a portion at least of cancers as being tobacco related that are probably not tobacco related. And I guess the other thing I would say is that as I over my career have sort of looked at cancers, you see that it's not all one thing. It's not all just, it's a lung cancer and they're all the same. You see that, the ground glass opacities, that's a different beast. Yes, they're lung cancers, but they behave differently. They seem to have a different cause. They seem to be just a different disease. And, I think we need to take a fresh look, I think, at how we interpret that. And I think that some of the, genetic analyses that we're able to do, I think is allowing us to be able to do that in a better way.
Frank has literally published a paper entitled Shades of Gray. So he's written just about everything. So I want to thank the panel. Emily, are you going to come up for the next? So Haley